Chapter 1. Parasitic biliary and hepatic infections. I. Fascioliasis, Fasciola Hepatica. Overview. Fascioliasis is a zoonotic trematode infection caused by the liver fluke Fasciola Hepatica. The infection involves an acute larval migratory phase through the liver parenchyma, followed by a chronic biliary phase where adult flukes reside within the large bile ducts. This disease is significant due to its potential to cause hepatic damage and its association with cholangiocarcinoma in chronic cases. Etiology and causes. The primary mode of transmission is through ingestion of Metacercariae encysted on aquatic plants, such as watercress, or in contaminated water sources. These Metacercariae are the infective larval stage that, once ingested, develop into adult flukes within the host. Pathophysiology and mechanism. The life cycle begins with larvae existing in the duodenum, penetrating the intestinal wall and peritoneum, then migrating through the Glisson's capsule into the liver parenchyma for approximately 3 to 4 months. The larvae then enter the biliary system, maturing into adults that reside in the bile ducts for 3 to 4 years. The adult flukes possess a spinous integument that causes mechanical damage to the biliary epithelium, leading to inflammation and fibrosis. Persistent infection can result in hepatic and biliary fibrosis, ductal hyperplasia, and an increased risk of cholangiocarcinoma. Larvae can also migrate ectopically to sites such as the peritoneum, muscles, brain, subcutaneous tissues, or urinary tract, causing various clinical manifestations. Clinical features. The disease manifests in 2 phases. Acute, hepatic/invasive phase. Symptoms include right upper quadrant pain, hepatomegaly, fever, vomiting, diarrhea, anemia, allergic symptoms like urticaria, and hypergammaglobulinemia, IgG, IgA. This phase results from larval migration and tract formation. Chronic biliary phase features recurrent biliary colic, cholangitis, cholecystitis, jaundice, anemia, hypoproteinemia, and edema. These symptoms are due to adult flukes causing intermittent obstruction and inflammation within the biliary system. Investigations and diagnosis. Diagnosis involves multiple modalities. Laboratory tests. Eosinophilia can be prominent, with eosinophils exceeding 50% of total white blood cells, although it may be absent in chronic cases. Anemia and cholestatic liver function test patterns are common. Serology, particularly FOS2, ELISA, offers high sensitivity, 92.4%, and specificity, 83.6%, for acute infection. Stool examination for ova may be negative in early stages and requires repeated testing in chronic cases. Imaging studies such as ultrasound and CT reveal characteristic features like heterogeneous liver lesions and tract-like hypodense lesions, respectively. ERCP and EUS can visualize flukes as echogenic or filling defects within the bile ducts. Differential diagnosis. Includes pyogenic liver abscess, necrotic hepatic neoplasms, and other causes of cholangitis or cholecystitis. Management. The mainstay of treatment is pharmacological, with triclobendazole being the drug of choice at a dose of 10 milligrams per kilogram orally, repeated after 12 hours, achieving cure rates around 90%. Praziquantel is ineffective against Fasciola. Bithionol serves as an alternative. Interventional procedures such as ERCP are indicated for biliary obstruction or worm extraction. Surgery is reserved for complicated cases or diagnostic purposes. Potential complications include fibrosis, cirrhosis, cholangiocarcinoma, and biliary obstruction. The prognosis is generally good with appropriate therapy, but reinfection can occur in endemic areas. Key data. Adult fluke lifespan, 3 to 4 years. Egg production begins approximately 4 months post-infection. Serology sensitivity/specificity, 92.4% per 83.6%.